Good evening, everyone. And I think we'll get started. There are still people coming in, but welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. My name is Leslie Rattan. I'm really pleased to be moderating our webinar series that was developed for individuals that have suffered from concussion, from their families, as well as healthcare providers. And if you've been with us before, you know that our sessions focus on various aspects, symptoms of concussion. And we start off with a expert speaker, and then that is followed by a question and answer period where you can get your questions answered. The sessions run every other Tuesday night at 6 p.m. And just before I move any further, I'd just like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we're meeting virtually, I would like to take a moment to acknowledge the importance of the lands which we each call home, to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So back to our webinar, just so that you know, if you've missed any of our previous webinars, they are recorded and available on the Canadian Concussion Centre website. Christian will likely be putting the link into the chat, so you can find that there. Also, just for this evening, in terms of the Q&A, if you look to the bottom of your screen, you'll see a Q&A. So if you do have any questions for our speaker tonight, please enter them there. There's also a chat button, so if you have any technical concerns, please enter those there, and Christian will can help you out. So just before I go any further, we always run a short poll just to get a sense of who is in the audience. So I'll just give you a second to click on whichever category you fall under. And okay, great. So for this evening's session, I'm really happy to welcome back Dr. John Rutka, who's going to be talking about dizziness after concussion. Dr. Rutka is a professor of otolaryngology, head and neck surgery at the University of Toronto with a subspecialty interest in otology and neurology. He is the co-director of the UHN Center for Advanced Hearing and Balance Testing and the Hertz Multidisciplinary Neurology Clinic. His chief academic interest has been in areas of topical and systemic ototoxicity, canal-based surgery for dizziness, the conservative management of patients with vestibular schwannomas, time trends in the surgery for chronic ear disease, and the evaluation of dizziness in the head-injured patient. His CV lists over 130 peer-reviewed publications and 4 textbooks, in addition to numerous book chapters, supplements, and non-peer-reviewed articles. And with that, I'm going to turn it over to Dr. Rutka.
Thank you very much, Leslie. And welcome everyone tonight, and thank you for attending. I'll go on for about 30 minutes today, maybe a little bit less, maybe a little bit more, and then we'll be pleased to answer any questions that you might have, concerning dizziness that occurs after concussion, which is a pretty common symptom, all things being said. I work at Toronto General Hospital, which is what you can see on the screen there. The purpose of today's lecture is really to look at what the literature says about dizziness following concussions, to appreciate the fact that we can have a spectrum of inner ear disorders that occur after a concussive event, and then the role for vestibular rehab therapy. You have had time with Shalene Solway a few weeks ago, and she would discuss with you what vestibular rehab therapy can do as a result of the therapy she provides as an advanced practice physiotherapist. We'll learn about something called the particle repositioning procedure, Epley maneuver, for the management of post-traumatic benign positional vertigo, which is the most common organic problem that we see after head injury. And really, we'd like to know, if you're a physician in the audience, who you should refer to if there's post-concussive dizziness, and what are the red flags that we look for as practicing physicians. So by definition, I'm sure you'll find there are many definitions regarding mild or minor head injury, but it's really defined as a closed head injury that may or may not be associated with a loss of consciousness, usually for minutes if there is a loss of consciousness. The Glasgow Coma Scale, which is the gold standard for grading basically concussions or head injuries, usually is just minimally affected in a sense. When you have a scale of 13 to 15, that's actually almost quite normal. 15 is normal. There's resolution of post-traumatic amnesia in 24 hours, and imaging, if done shortly after the accident, tends to be normal without evidence to suggest any significant anatomic brain trauma. There are some facts that you should be aware of that following head injury, headaches, neurocognitive and neuropsychologic complaints, in other words, troubles with memory loss, troubles concentrating, focusing, mood change, anxiety, depression, and dizziness are the three most common symptoms that we actually see. And another fact is that although dizziness is very common after a head injury, the finding of what we would call organic evidence for injury to the inner ear is relatively rare. And most causes of dizziness after head injury are really unknown to the practitioner, or they may be explained by other factors. And we often call this medically explained or non-organic factors. And we'll spend a little bit of time talking about that later in the lecture. And that of the common inner ear problems that we see, benign positional paroxysmal vertigo, or BPPV, is the most common recognized inner ear disorder. And this is where you have crystalline disease and you have little crystals floating around in the semicircular canals that will give rise to dizziness when you put your head in different positions, for example. There is a difference between dizziness and vertigo. Dizziness is an all-encompassing term that we use to discuss things such as giddiness, lightheadedness, feeling as if you might want to faint. And it also includes vertigo, but vertigo by definition usually is a hallucination of movement. Either you or the environment is moving, and that generally represents an abnormality involving the vestibular system, either peripheral for the most part, or sometimes within the central nervous system. So really the important answer here is that all vertigo is dizziness, but not all dizziness is vertigo. So when we talk about vertigo, we think of things spinning and circling around. And here is an example of what you might see if you were vertiginous. Just think of when you were younger, spinning around in a circle and stopping, your environment would be moving. Well, that's what this person might be experiencing. And that usually happens if there are abnormalities involved in the ear. However, we sometimes use the senses in our inner ear to give us great thrills. And so if you're out, for example, on a roller coaster and you're going up and down an amusement park, you're really challenging a different set of organs in the inner ear, and those are called the otolithic organs. That gives you the feeling as if you're falling, for example. And so those are the otolithic organs. We have to go over this a little bit in detail, and I know that many of you are not familiar with the anatomy of the inner ear, but I think just for the sake of letting you know, we have organs that are called the semicircular canals, where my arrow is here, and these are responsible for what they call angular acceleration perception. And what they do is they allow your eyes to move in an equal but opposite direction to head movement, and that's called the vestibular ocular reflex. You also have other organs inside the central part of the inner ear in this area here, and those are called the otolithic organs, and they're linear translation receptors that are responsible for the perception of gravity. Or if you're, for example, linear translation perception, you are in a car and you're starting, you're stopping, for example, those are the organs that are very, very important. And so the combination of all these organs forms what they call the vestibular labyrinth, and then the hearing part is juxtaposed to the actual vestibular part, but we're going to talk mostly about the vestibular part today. So here's a stylized diagram demonstrating the angular acceleration receptors, which are these semicircular canals. And then in the central part of the inner ear, you have the otolithic organs, which are called the utricle or the saccule. Sometimes they're called the macular organs, and they're responsible for linear translation perception, either to gravity or, for example, if you're stopping or starting on the horizontal plane. So just a few trivial facts is that each inner ear contains three semicircular canals and two otolithic organs. And I've mentioned what the organs actually do inside the inner ear. And the vestibular nerve is the cable that connects the inner ear to the brainstem, and that's what transmits electrical activity from the inner ear in the brainstem to allow the brain to understand what is happening in terms of your movement relative to your environment. We have two nerves. They're called the superior vestibular nerve and the inferior vestibular nerve, and they will innervate different parts of the inner ear. And one thing that I find is a very interesting fact, and that we um, often report but don't think much about, is that 80% of the electricity that goes along the vestibular nerve comes from the otolithic organs, and only about 20% comes from the semicircular canals. And yet we have a lot of tests that will check the semicircular canals, but very few that will check the otolithic organs. And so the reality, even to this day, is we know very little about the role of the otolithic organs in the management of individuals who have dizziness and imbalance. I think many of you are aware of the astronauts when they go up in space. There's a phenomenon called space sickness, and the astronauts often spend a day or two, and they don't really show them on television, but they're actually quite violently ill. And that's what happens when you take away the effects of gravity on the otolithic organs. And so that's about the only way that we can really check and see what happens to people with regards to the otolithic organs when we take away the sense of gravity. Anyway, to make matters a bit more complicated, we have a number of reflex loops inside the brain, and information comes from the inner ear. It will come via the vestibular nerves into the nucleus in the brainstem, and there you will have ascending pathways that will transfer electrical activity to the oculomotor nuclei, which will then send motor neurons, if you like, to the eye muscles to allow the eyes to move in an equal but opposite direction. That is called the vestibular ocular reflex, which is really from the semicircular canals. But from the otolithic organs, we have what they call the vestibular spinal pathways, where information comes in from basically the utricle and the saccule inside the otolithic organs, and it goes into the vestibular nucleus, and then it travels on both sides, if you like, of the brainstem, but mostly down to the effector neurons in the spinal cord that allow the muscles to move. And this is what happens, for example, if you feel you're falling. You have a righting reflex that prevents you from falling, and that's what the otolithic organs do. In the absence of otolithic organs or damage there, sometimes you're more prone to falling. And what we do identify is that if you had a lesion, for example, where you knock out the inner ear from trauma, then we expect to see a number of findings. And these are classic findings in someone who has lost balance activity from an inner ear acutely. And these will include the findings of nystagmus, which represents a disruption of the vestibular ocular reflex. And you'll see a rapid rhythmical movement of the eyes to one side, depending on which side is injured. Uh, if the vestibular spinal tracts are involved, for example, over here, then you'll fall to the side of lesion because the vestibular spinal tracts travel along the ipsilateral side of the actual spinal cord. And because you have connections with the cerebellum, which is responsible for rate, rhythm, speed, and accuracy of movement, in other words, coordination, you'll have ataxia, you'll look like you're drunk, you'll have past pointing, and many people have been pulled over by the police who had an acute attack of vertigo, and they present with these findings, and the officer sometimes believes that you may have been drinking too much. The reality is that this is what happens if you have a disruption of the vestibular cerebellar tracts. And then finally, if you do have an acute loss of balance activity, you lie perfectly still, you don't move, because that makes you nauseous to the point of vomiting. And so these are the things that we look for in someone who has an acute loss of balance activity. There are some clinical tests that we do. This is really the vestibular ocular reflex. It's called the Hamelgi maneuver. And this is a test that your doctor will do on you if you do have dizziness. And if you look here, this is one of our fellows. We move his head quickly, and the eye should move in an equal but opposite direction to head movement. And that's called the vestibular ocular reflex. Now, here's a gentleman who has a loss of balance activity, and you'll see the eyes, if you look carefully, they will kind of move, but in a staggered fashion. And if we put this now into slow motion, what we actually identify is you can see it much more carefully there. And that is called an abnormal head thrust test, or eponymously, it's called the Hamelgi maneuver. And here we'll just move one more time. This will give you a very good view of what happens to someone who's lost balance activity and what their eyes look like when you move their head quickly. and it just takes time to get over to that area. So that is called a positive Hemelgi test. Now, if you lose, for example, or have pathology involving the oolithic organs, sometimes you have falls, and you can have falls and they're called drop attacks. And this is where you do not lose consciousness, but actually you may just fall to the ground as if you're being pushed or pulled to the ground. And this is a gentleman here. This is a CCTV. He owns a gym. And what you're looking at is they've captured this on his television. Now, he's in the gym, but this is on his television. And he has what they call otolithic dysfunction. And if you look, you'll see one of the very first captures of really a drop attack that I think anyone can demonstrate. So here's the gentleman. He's in his gym right now. He's just standing there, not doing anything. And again, he's just waiting for a few more seconds. He just falls right to the ground. So that is really the presence of a drop attack, and that's sort of what it can look like. Now, sometimes drops can be actually quite subtle. So this is him walking in the same gym, again captured on his television, and here he is, and he just kind of falls off to one side, but luckily he can catch himself. But if he didn't, he might fall and injure himself, and that's usually thought to be the result of what they call otolithic dysfunction. Now, if you wonder why I have gotten involved in head injury, well, I do quite a bit of consultation work for the Workplace Safety Insurance Board. And since 1998 to really 2018, we have assessed over almost 4,300 head injured workers who had complaints of dizziness. And this is a sort of an important paper because it looked at what they call the inner ear disorders after head injury, but we excluded positional vertigo. So there are other head injury symptoms that can occur besides that of positional dizziness. And anyway, this is an important paper if someone wishes to read it in future. It is a very good update of really what we find in this very large big data population. And what we actually identify is that again, almost 4,300 patients, but the majority of patients we saw from the compensation board basically had minor head injuries, and this is really what a concussion is all about. What we identified is that we could identify a peripheral inner ear disorder as a result of their head injury in about a quarter of the patients. The most common type of injury was positional vertigo, in other words, lying down, rolling over in bed, that sort of thing. You became dizzy for seconds usually, or you had a history of it. But then we had injuries to the actual inner ear itself, where there was actually trauma to the inner ear, and they presented with really a spectrum of different types of inner ear disorders that could be episodic vertigo lasting for minutes to hours, drop attacks as well, and so on and so forth. We also found that about a quarter of the patients had what they call the cognitive vestibular disorder. In other words, what we're looking at is the generator does not necessarily come from the inner ear, but may have been the result of an inner ear disorder, and now something else has taken over, and we'll go over some of that a little bit later. Injuries to the brainstem were quite rare in this population. Really about a quarter of patients had hearing and balance loss we could identify on testing. And like everything else, about a quarter we didn't know what the cause was, for their dizziness. So we can't always be certain exactly what happens with these individuals. And of the individuals that we did see, again, excluding positional vertigo, we had a certain number of people that would have a spinning and circling of their environment that would occur episodically, and that's called recurrent vestibulopathy. Some patients would have a feeling as if they're being rocked back and forth on a boat or a ship, lasting from minutes to hours, and that was also another recurrent vestibulopathy, but based on injury to the otolithic organs. Many patients who had a loss of balance activity had an uncompensated loss. Usually the brain's pretty good about compensating, but sometimes it doesn't. And so every time they move quickly, they might feel a little transiently dizzy. Meniere's disease, which you probably have heard about, and we'll talk a little bit about that later, was rare, but we did see it in some patients who had head injury. But again, it was not all that common and probably no different than what we would see in the average population. There's a condition called delayed lymphatic hydrops. It's a variant of Meniere's disease. These are individuals who might have had a traumatic hearing loss, and then months, if not years later, would then get attacks of dizziness going on from minutes to hours. Drop attacks, I showed you a few examples of that, and so on and so forth. And so these were sort of the peripheral vestibular causes that we would see arising from inner ear pathology, again, excluding positional vertigo. So we'll spend a little bit of time talking about positional vertigo, but most of the time patients would tell us they would get dizzy if they were to lie down, roll over in bed, look up, bend over, and it would last for seconds. But when we examined them, we really didn't find much going on, and they were the historical positional vertigo. And then we would see other types of positional vertigo. It's quite classic, which is relative crystals floating around inside of the balance canal, specifically the posterior balance canal, which is most gravity sensitive. We had also identified other types of positional vertigo, which was the result of these crystals getting into the other balance canals, the superior, the posterior, or perhaps there was involvement of the oolithic organs as well too. We had some people who had recurrent vestibulopathy. I mentioned that earlier. These are where you have episodic attacks of vertigo going on from minutes to hours. And if you had an uncompensated peripheral vestibular loss, if you move quickly, you might feel unsteady on your feet, but it would only last for a few seconds or so. The Hall-Pikes maneuver is something that is done to look for positional vertigo. It is the head hanging position, and it's the classic test that is done to check for this condition. The cause is really secondary to the finding of little crystals inside the posterior balance canal for the most part. And this is just an example of what a crystal looks like inside the posterior canal. This was an operation done to try and block the posterior canal to prevent the crystals from moving. That's called a canal occlusion procedure. It is only done in patients who have really bothersome positional vertigo that is not treated or cannot be treated with physiotherapy. And you can see the crystals inside the membranous labyrinth moving there. So this was really good physical evidence to show that these crystals actually did exist. Anyway, the finding of these crystals actually led to the development of maneuvers. And you may have heard something called the Epley maneuver, and maybe some of you have had it performed on you. This is where we try and move the particles out of the posterior balance canal into a more silent part of the inner ear. And it really requires a patient to lie down. Hopefully the crystals will float into the mid part of the posterior canal. We then rotate their head off to the side, and the crystals will further rotate within the canal. And then when we sit them up, hopefully the crystals will drop down into the oolithic areas, which is where the crystals came from. So this is a video which demonstrates the actual maneuver. There is some sound there. Hopefully everyone will be able to hear it. And this is my colleague Lauren Parnes from the University of Western Ontario, who about 25 years ago shot this video. But I think it's still relevant to this day, and it's a very good video for understanding how the maneuver works and why we think it works.
Maneuver begins with the patient seated lengthwise on a stretcher. The patient is then brought back from the seated to the head hanging position on the side of the affected ear, and the eyes are observed for nystagmus. After a short latent period, which can range from 2 to 10 seconds, the nystagmus response crescendos, plateaus, and decrescendos with a limited total duration of approximately 15 to 20 seconds. In this cutaway model, the fluid-filled tubing represents the posterior semicircular canal. Note the directional movement of the particles as the head is tilted. The head is kept stable for 1 to 2 minutes. Then, with the neck fully extended, the patient is rolled onto the opposite side. With the force of gravity returning the particles to the utricle, the eyes are again observed for nystagmus. If successful, the response will be in the same direction as was seen during the first part of the maneuver. As demonstrated here on the model, turning the patient also turns the affected posterior canal 180 degrees, moving the particles along the canal back to where they originated in the utricle. After about 1 minute of observation, the patient is returned to the seated position, and the eyes are once again examined. When the maneuver has been completed successfully, nystagmus should not be observed. Maneuver begins.
So that is the particle repositioning procedure, and it is actually one of the best things that we can do for patients, and it's successful, really upwards in the order of about, I'd say about 90 to 95% of the time in terms of helping an individual who may have positional vertigo. And yes, it doesn't work in everyone, and sometimes you have to do the maneuver many times, but usually it does help. So for the people that are in the medical world, if you're wondering, when should I refer someone for a medical assessment, specifically to a neurologist or perhaps someone who is a neurologist like myself, we look at those individuals who have persistent symptoms of dizziness and balance that do not improve or resolve over a 3 to 6 month time frame. Most of the time, post-concussive dizziness does get better given time, but if you have someone where it persists, again, that's an indication. And if you have patients who have episodic vertigo and dizziness that's not positional in nature, lasting for minutes to hours, or unprovoked drop attacks, again, those would be other reasons to refer off to a subspecialist. And anyone that has complaints of hearing loss, tinnitus associated with their concussion, and anosmia, which by definition is smell dysfunction. Believe it or not, the first cranial nerve or the olfactory nerve is the nerve that gets injured the most often in terms of head injury. And you were talking, or Ms. Solway gave you a talk about 2-3 weeks ago about vestibular rehab therapy. Patients should be referred if they have a history highly suggestive for positional vertigo, and this is where you lie down, roll over in bed, you feel dizzy, look up, bend over, feel dizzy, so on and so forth. Dizziness that's aggravated by head movement. This may represent an uncompensated balance impairment. And also patients who may have dizziness with motion relative to themselves, actually. And sometimes you see this, patients will complain that if they're in a crowded shopping mall, in the supermarket looking up and down at things, they feel very dizzy. If there's a lot of action around them, for example, they're in a car driving and cars are coming back and forth around them, that may bother them. So again, these are things that vestibular rehab therapy can help. At least try and promote compensation for any loss that someone may have or habituation for their dizziness. Just always remember, however, that vestibular rehab therapy is limited to some degree. We find that it may not necessarily help people who may have an underlying mood disorder, and the mood disorder may adversely affect the physiotherapy from being beneficial. So just please keep that in mind. There are some controversies following concussion. Cervicogenic vertigo is if you've had a whiplash injury or injury to the neck. Some people say, well, that's where the problem is. Certainly chiropractors have made their living looking after patients like that, and orthopedic surgeons would probably agree to some means by that as well. The cervicogenic vertigo, if we look at cervical proprioceptors, we really don't know all that much about them. And for the most part, it is said that information that comes into the vestibular nucleus usually comes in from the inner ear and not necessarily from the neck. Following head injury, headaches are common. Migraine is common as well too, but migraine-associated vertigo is another condition that's often said follows head injury. I'm a little dubious about that sometimes. And then finally, we have what I call syndromes of cognitive vestibular dysfunction. There are general terms that are given for this, such as medically unexplained dizziness, chronic subjective dizziness, non-organic dizziness, psychogenic dizziness. And then we have specific terms that are sometimes applied to this, and that's where you have things such as persistent perceptual postural dizziness, Melda-Barkman syndromes, post-traumatic vision syndromes, so on and so forth. But the important thing is that you may have some vestibular injury initially, but the driver or the generator now of the dizziness is coming from a different part of the brain, but not necessarily from the inner ear or from the vestibular nucleus. And this is really something that really is best treated in a multidisciplinary fashion. And that's what we have at our Hertz clinic, for example, at Toronto General Hospital. And as I mentioned earlier, the epiphenomenon may have been an acute injury or vestibular event, but the generator is usually coming from higher cognitive vestibular centers within the brain. Please remember that in many individuals who have a head injury, the dizziness is real to them, but where it's coming from is not necessarily the inner ear. Vestibular rehab therapy, in many instances, is not going to prove beneficial. Sometimes people do get some improvement with sedatives, antidepressant therapy, for example. That just takes the edge off the dizziness that people have. There can be a role for something called cognitive behavioral therapy, discussing the dizziness with the patients. And also please remember that there's a complexity here in that the interplay of litigation, compensation claims, workplace issues will adversely affect any treatment that we provide a patient, and it serves to serve the pot, and the patient may not necessarily improve regardless of what we do. So that is basically my presentation today. I'd just like to say that in summary, the most common of the organic inner ear related disorders we see is post-traumatic benign positional vertigo. Certainly positional vertigo or dizziness is complained of by many patients, but we do not find it as often as what patients tell us. There are other causes for dizziness that have to be looked at, and that is really the role or interplay, if you like, of an individual's mental health as well, and whether that affects their coping mechanisms or may actually be responsible for the generation of the dizziness that a person may have as well too. There are sometimes surgical procedures that can be done, but rarely. I think there's a lot of unknown about the dizziness, but certainly our studies have demonstrated that we also have a significant number of people that, despite all the testing we do, despite all the imaging, we really still can't find a diagnosis for them. So right now I'll stop, and I guess I would ask maybe Leslie if you wanted to take over as moderator. I'd be pleased to answer any questions that there might be.
Thank you so much, Dr. Rutka. That was an excellent presentation. So I am just going to ask any of you that may have questions to, again, please just enter those into the Q&A. Okay, Sarah has said, the intricate relationships of brain, ears, and eyes is fascinating. 3 weeks after my last concussion, I developed vertigo and had an excellent referral where I did 2 sessions with the Epley maneuver, which resolved the symptoms nicely. And yet, it was with the prescription of horizontal prism therapy glasses 2 years later that fully resolved motion-related symptoms. I definitely had a multimodal approach in effect by this time too. And she's just wondering if this is a common scenario. Is this something that you see?
Well, I mean, usually, yeah, I think it's not just one thing for individuals. Again, following concussions, we have all sorts of things that happen to people. I mean, headaches, neurocognitive, neuropsychologic issues, as well as, dizziness. So that's really the triumvirate, if you like, of the complaints that we see. And yes, sometimes it does need a multimodal approach. You can have organic pathology, but at the same time, you can have mental health issues as well. And so
Mm-hmm.
I think that this is important as well. So, I mean, one shoe doesn't fit all, as they know, and so this is what you try and do in a multidisciplinary approach. You should try and, look at all aspects of that person's presentation, not just one.
Absolutely. Okay, thank you. Um, okay, Catherine has indicated she had a head injury 7 years ago. I have tinnitus and hyperacusis. My ENT said everything is fine with my ears. The hearing test is normal. I also have dizziness. Lately, I've been feeling tingling in the right ear. Usually is only pain, and wondering if this is something that you've seen.
Oh, I think I've seen most things in life so far after 40 years. Yes, it's not unusual. And again, please don't get me wrong. I think physicians sometimes don't realize that, patients have problems. The analogy is taking your car to the mechanic. There's a problem there, and you take it to the mechanic, and they look at it. They say, "Oh, there's nothing the matter with it." But no, we agree that you have problems. The issue here is trying to demonstrate if we can find an abnormality on some of the tests that we have. And even if we can't find an abnormality, the history is very important. And as far as your tinnitus and hyperacusis is concerned, there are treatments available, but again, you have to go to the right people to have that looked at. I'm glad that your hearing seems to be okay, but you do have the tinnitus, and that can, be treated in many ways. Not necessarily we can get rid of it, but I think we can make your life a bit better symptomatically. And there are again a number of options that are available there. But again, it would be important to go and see the appropriate individuals to look at that. Hyperacusis is a more difficult problem to treat, in my opinion, sort of thing. This is what we mean by that is that you're intolerant of noise levels that at one time you were very tolerant of. And so sometimes you almost become a hermit. You don't want to go outside because any noise seems to bother you. You tend to wear earplugs or ear muffs. And that's probably the worst thing you can do because you need a certain amount of noise. And when you take them off and go outside again, it's just absolutely deafening and you have to go back inside. So it can be a problem. But again, we have to look at the whole person who has tinnitus. Sometimes the tinnitus can be made worse if there's an underlying mood disorder. Maybe that should be looked at. Maybe other imaging studies are necessary to see if we can find an actual cause, what's going on, and maybe there could be something treatable. But for the most part, it's learning how to cope with the tinnitus, but with the help of medicine at times, with the help of, again, psychologic means, if you like, therapies, things like that.
Great. Thank you very much. Marisa is asking, what is the best way to improve symptoms when they are aggravated with motion around? So being in a busy environment, when you're driving. Also asking, would hearing aids help at all? Sometimes it's hard to tell if it's the eyes or the ears that are overwhelmed.
Yeah, what I don't think hearing aids will necessarily help, unless you have a hearing loss, in which case then they could. But if you have motion intolerance or motion, if you're intolerant of motion relative to yourself, or you have a visual vestibular syndrome of some type, that can be associated with a loss of balance activity, and the brain is getting abnormal signals from vision, and well, normal signals from vision, but they're getting abnormal signals from the inner ear, for example. And there are different therapies. Usually, they're in the realm of different types of physiotherapy you can do to help you do that. They will challenge you, but at the same time, hopefully, the brain will get the picture of the signals there. If there is any underlying anxiety that may be again fueling the fire there, again there are medications that can be given that may help as well too with that. So those are options that you can certainly look at.
Great, thank you. And the next question is actually asking, can you describe more about the mood disorder you mentioned? Is that related to the concussion or preparation? I'm not sure about that and why that. So they're asking why the mood disorder needs to be treated first, and also wondering who performs the maneuver. I'm assuming the Epley maneuver.
Well, if you just have a positional vertigo, which is due to really a physical cause, you have these crystals floating around the inner ear. If you go ahead and if you do the maneuver, then obviously the patient will get better if that's the only thing that is bothering them. But what we often see is we often see a number of patients that come in from, have had head injuries and they have persistent dizziness. It doesn't go away. It's always there. It affects their well-being. They become so focused on it that in a sense, it takes over your life. And then the question is, well, why is that? And so what we have identified is that people can have varying degrees of depression, anxiety. Still waters run deep. You may not be aware of it yourself, but there may be things going on. And so it's really important to look at that. And that's an aspect that people like myself, even though I'm an ear surgeon, I spent a lot of time, I really had no training in looking at the mental health of patients or the psychologic aspects of their presentation. And I'm very happy that within our multidisciplinary clinic in Toronto, we do have vestibular psychiatrist who works with us, and we have a neurologist, neuropsychologist as well too. And so we're trying to look at the whole picture now. And again, the event may have been some loss of inner ear activity, but then what's the generator? What's fueling the fire? Why does it keep going? Sort of thing. Because the mantra that we have in our field is that if you've had a loss of balance activity after trauma, and if it's stable and it's not fluctuating or changing, then the brain should compensate for that. And specifically if your brain is healthy. And then why isn't that? And that's where you start looking at, well, are there other explanations that we can look at? And so this is where the whole picture of the mental health comes in, because we're all, physical, and we're all, again, psychologic in terms of presentation. It depends on what the balance is, obviously, but that's sort of something that we look at if you want to look at the whole person.
Absolutely. And as far as the maneuver, I'm thinking maybe they're just wondering, does it have to be a doctor that does the maneuver? Can you do the maneuver at home?
Yeah, no, please read up on it on the internet if you like. It's called the Epley maneuver, or the physical or particle repositioning procedures. You can try it at home. Sometimes, however, it's probably best if a therapist were to do it. And to be perfectly honest with you, the physiotherapists are much better trained than I am to deal with this sort of maneuver. Where I would get involved is if there is persistent positional dizziness that's refractive to the uh, particle repositioning procedures, Epley maneuvers. That's where I might get involved in sort of thing. But no, I think really the realm of physiotherapy, I believe, are probably going to be the best people to look at this.
Great, thank you. I had a concussion a few years ago and completed vestibular therapy pretty successfully. However, I often feel a little bit dizzy and my balance has not returned to pre-concussion levels. Is this common? Will this ever go away, or is it something I just need to live with?
Well, I guess it would depend on what has happened, for example, to the inner ear as one example. I don't know if you had testing or not, but we have probes of inner ear activity that we do to check and see how the inner ear is functioning. And then, what you really would like to do is to do the tests we have available to see, in fact, what we're starting with. And then the goal of physiotherapy would be to see if you can try and improve upon that by promoting compensation and adaptation, habituation. Those are the big buzzwords that are used in physiotherapy. But sometimes people don't necessarily always compensate. And then the question, well, why is that? And that's where then you have to start looking a little bit more carefully. Maybe imaging is important to see is there anything that might be preventing that from happening. And again, we'll go back to the old, psychological health of an individual, mental health of an individual. Again, that can be another thing to look at. Please remember that after head injury, you can have changes that occur inside the inner ear, and that can give rise to further bouts of dizziness in future, sometimes in a delayed fashion, because the changes in the inner ear lead to different types of disorders. And this is where we talked about a spectrum of inner ear disorders that you see sometimes in an individual. But really, it would require you to be, I guess, assessed, in a specialty clinic or with someone who has an interest in this area.
Great, thank you. Uh, Next question. I would love to hear more about olfactory nerve damage. I am much more sensitive to perfume and cigarette smoke post-concussion, in addition to light and sound sensitivity.
Yeah, I was going to say you have olfactory dysfunction by definition because it's not normal. But at the same time, you're very lucky that you didn't lose your sense of smell completely. And in those people that do lose their sense of smell after trauma, you have a 2-year window where it may improve, but there's nothing we can do surgically or medically to try, at least in my opinion, to improve that. And if it doesn't improve over 2 years, then chances are it's not going to. Yes, again, heightened sensitivity to light, to sound, to smell, to external stimuli is very common in individuals, who've had a head injury. Is it an issue with regards to the filtering mechanism in the brain? We get all sorts of information thrown at us. Is it the fact that, normally we can sort of filter out some of the extraneous things that happen to us? Why is it such that we can't? And the analogy that we have, and again, it's not with sense of smell, but if you're looking at an airplane pilot when he's landing a plane, for example, he's able to exclude basically all the things around the plane as he's landing. His eyes are focused on the tarmac, and he just wants to land the plane. But he's not looking at the buildings around. He's not looking at the cars that are moving on the highways around. The snow that might be falling. So your brain's pretty good about filtering some of that information out. But after head injury, that filtering mechanism can be changed. And the question is there any structural damage? Usually not. Could it be biochemical injury? Maybe. Could this be a different form of anxiety coming through in you? We certainly can see that sometimes. So those are just thoughts that we have in mind, and there's sometimes there are medications that we can take that can be helpful.
Great, thank you. Anna says, I have permanent vestibular damage in one of the canals. The hairs are damaged, which interferes with my balance. Currently, I'm on medication to help with the vestibular damage and is wondering what happens as you age with this sort of difficulty. So asking, if you've got vestibular damage, as you enter into your 60s and 70s.
Yeah, unfortunately, it's insult to injury. The insult is basically getting older, and it happens to all of us. We have neuronal dropout, and so therefore you lose the reserve that you would normally have. So chances are your balance may get worse as you get older. Not terribly worse, but you may notice that it gets worse. You may be more likely to use a cane, for example, compared to someone, maybe you'll need it at age 80 rather than age 85, that sort of thing. So that's what we kind of see sometimes. So it's insult to injury. And I guess that's all that I can say. But again, we believe that by being active, by promoting compensation, as you can with vestibular, physiotherapy. By being active, you retrain the brain and you use that reserve. But, again, you will be losing reserve as you get older, I'm afraid.
Okay, thank you. Melinda's asking, do you know or have any evidence-based articles or recommendations, I guess, for any for tinnitus? As I know this can be hard to diagnose and create to create a treatment plan for.
Yeah, you can look up if you like to the American Academy of Otolaryngology Head and Neck Surgery. They have all sorts of platform papers on tinnitus, and they're evidence based. So you could look at their audiologists as well too. Will have again evidence based treatments for tinnitus. Uh, there are many things tried. Not necessarily everything works, and again, it's one shoe doesn't fit all, but there are different management options depending on the individual and what else they may have in terms of their presentation. Things such as cognitive behavioral therapy have been looked at, and again, there's evidence base for that. There's some evidence base for some of the medications that are used. One of the common ones that's used is called Elavil or amitriptyline. Another one is called Aventil or Nortriptyline, and they seem to help. We do know that people get benefit from using background noise strategies. For example, putting on a radio or something that's more pleasant to listen to. So competing background noise strategies, avoidance of any food or drink that may make your tinnitus worse. So if you're having a lot of Coca-Cola, for example, or a lot of coffee, which contains caffeine, both do, that can sometimes make anything worse for you. And again, if there is any underlying depression, that should be treated. Because again, if you have an organic problem, even if we can't find out what it is, if it is tinnitus, for example, your mental health has to be in a better field, better position to get maximum benefit treatment we're going to give you.
Okay. Next question is every physiotherapist trained to do the Epley maneuver, and how many treatments are required?
I think in general terms, the answer is yes, but one of the problems is that I think you actually have to be an advanced practice physiotherapist. In other words, that you've subspecialized and you've had some extra training, specifically in balance related disorders. I think those are the best people to go to. Again, it's like being a general practitioner versus a specialist in medicine. You have some knowledge of the generalist nature of diseases, but specifically if there is an abnormality, then that may be a little bit more complex, and you really should see a subspecialist. We see a lot of people that have dizziness that they will say it's positional nature, but it may not be due to what we call benign positional paroxysmal vertigo, where you have crystals floating around in the posterior semicircular canal. And so I can't tell you the number of people that I've seen who will have complaints of positional dizziness. They're told that they have crystals floating around. They have numerous Epley maneuvers, oftentimes many, many times over, and it doesn't help them, only because the most important thing is diagnosis, diagnosis, diagnosis. You have to diagnose from. And again, it doesn't necessarily always come from a posterior canal response.
Okay. All right. We have a question about drop attacks. Curious if there's a reason why I would only have drop attacks while pregnant with their first child, had a handful of drop attacks back then, almost 2 decades ago, but never since, and seemed to resolve on its own. Then 4 years ago, sustained a traumatic brain injury in a car accident. And the past year, tinnitus came on and has stuck with them. Can tinnitus be from the brain injury? And what provider may be of help? So it sounds like they were having drop
Well,
attacks. It's sort of,
again, there are tinnitus clinics. Yeah. Yeah, I think that the tinnitus and the drop attacks are unrelated. But I'm glad your drop attacks have gone into remission. That's usually what happens with most people who have drop attacks. And again, if you ask enough questions in medicine, we don't have all the answers. And certainly it's something I just can't get my head around, is actually what causes a drop attack to occur. The general medical position is that we believe it's a loss of otolytic function function acutely, where you lose extensor tone in your extremities and you fall to the ground, but you don't lose consciousness. That's the most important aspect. If you do lose consciousness with a drop to the ground, then you have to have your heart checked, make sure you don't have an arrhythmia, and you have to make sure you don't have epilepsy. Those are the two things that we look for. But if you just fall to the ground for whatever reason, oftentimes people say they feel they're being pushed or pulled, but they drop to the ground, but without losing consciousness. That sounds very much inner ear related in terms of what the potential cause could be. And also don't forget that if you have, for example, things like a tripped knee, that can also cause you to fall to the ground. Sometimes you get some pain and you fall to the ground because of it. But classic drop attacks, although this is what we say in the medical world, the actual physiology just hasn't been worked out very, very well from what I can see. We're just trying to figure out what would cause a sudden loss of extensor tone to drop to the ground, and yet you would then bounce up and you feel okay afterwards. It's just difficult to know exactly what the pathology is there. As far as your tinnitus is concerned, I think unrelated to drop attacks. But that being said, there are tinnitus clinics that you can go to. They're usually run by audiologists. They tend to primarily do techniques called tinnitus retraining therapy, where you wear masking devices of certain types. They may talk to you about wearing hearing aids sometimes if you have a hearing loss, because again, by putting in a hearing aid, sometimes that will help the tinnitus. If you're looking more for the medical treatment, then you'd be looking at your family doctor prescribing certain medications for you. And again, if there's any change in your mood, just to be able to cope better with any problem that you have, that should be looked at as well by a psychologist or by a psychiatrist.
Excellent. Thank you. We've got a couple more. Dizziness and lightheadedness is my main persistent symptom, but it seems to be triggered by noises, things like repetitive fan, drone-like sounds. I'm able to be exposed to such noises much longer than at the beginning, up to an hour or so now, as compared to 30 seconds at the beginning. Places with a number of people are still an issue. Vestibular exercises weren't started until I finally saw a neurologist at 7 months after the concussion, which seemed to have helped. Balance has also improved, but still not back to normal. Are there any things that can be done to help treat sensitivities, dizziness? Who do I advocate to be referred to?
Well, again, you have to have a diagnosis. You've had a concussion, but then the question is what's happened with regards to the inner ears, the brain as a result of your concussion. So again, ear, nose, and throat doctors are, who you could see as the first pass. I can certainly arrange for you to have, testing done. Same with neurologists as well too. And then they can give you certainly a good going over to see if there's anything that kind of shows if your symptoms continue to persist. Then again, it's worthwhile going perhaps to a tertiary center where you can be more fully investigated by someone who has subspecialty interests. And we have neurologists, and we have, for example, ear, nose, and throat doctors. I'm one of them, and I specialize in what they call otology, which is ear-related disorders, and neurotology, which is ear-related disorders. And that's where I think you would probably need to go. Remember, it's a question of your diagnosis here. And when we hear about people where loud noise bothers them, there are sometimes inner ear problems that we look specifically for, but you need to have special testing for that, as well as special types of imaging performed.
Okay, great. Thank you. Okay, this is a bit of a long one. Okay, about 4 months, almost 4 months after my concussion, which was 5 years ago, I had the sudden onset of extreme nausea, most often associated with any type of movement. Checked several times for BPPV, never an issue. Nausea meds got me functioning and eventually was approved for 12 weeks of vestibular therapy, making progress enough that it sounds like a physiotherapist requested 12 more sessions. This was delayed through workers' compensation. Meanwhile, I was feeling better with prism lenses and vision therapy. When I did go back to vestibular therapy, I completely regressed. It was approved for twice weekly and included use of virtual reality. I never rebounded from that. We went back to once a week and no virtual reality, which helped, but again, haven't gotten back to where they were. Wondering what your thoughts and suggestions would be. And they're saying they're now taking anxiety medication and seeing a neuropsychologist weekly.
Yeah, I think that would not be unreasonable. But again, we try and look at the physical aspects of your presentation initially, and I don't know whether you've had any formal balance testing that was done. That would be something that we would like to look at. Again, we'd like to make a diagnosis. Again, if there is medically unexplained dizziness after we've ruled out as they say, the physical, then I think that that would be an appropriate thing to do, would be to see a psychologist or a psychiatrist, or maybe even your family doctor, if they're well tuned in terms of managing these types of problems. So yeah, I think I don't think there's any harm in doing that personally. But again, like everything else, we like to have a diagnosis as to what the cause is. And again, remember, dizziness is a very ubiquitous term. It can mean many things to different people. But then the question is, well, why do you? Most important thing. That's where really it comes down to diagnosis and diagnosis and diagnosis, and that's what Sir William Osler used to say back over 100 years ago. So that's really the important thing that we look for.
Okay, excellent. Okay, we just have one last question. Can BPPV symptoms reoccur often?
The answer is yes, they can. So even though you might be have gone into remission, come back just like the winter snow does from time to time. And yeah, we do see it. And that's why if you do go for physiotherapy, vestibular physiotherapy, you can learn the maneuvers and you can do them at home yourself sometimes when it does happen. And yes, we can see that. Again, remember that the crystals come from somewhere. If they cause true benign positional vertigo, they come from the old lithic organs. That's where they are. And again, when we do the maneuver, sometimes they go back to the organ where they came from and they stay there and they do not let loose. Sometimes we believe maybe they fix themselves to the posterior canal wall and they don't move, so they don't cause symptoms. Or maybe there's something else going on inside the inner ear that causes their release, from time to time. There's some fairly weak evidence, but it seems that positional vertigo outside of trauma is more common in the wintertime than it is in the summer, for example. One of the postulates is that the crystals require, because they're made of calcium, require vitamin D. And so what people have been saying is if vitamin D levels are low, it may affect the actual formation of the crystals inside the inner ear, and they may not necessarily be the same crystal formation that you might see, for example, during the summertime as you would in the wintertime. So that absence of vitamin D may be something that we can look at. And again, this is being talked about back and forth in our literature for many decades now. But in people that have recurrent bouts of positional vertigo, where it occurs, sometimes we do recommend maybe they take a vitamin D supplement to see if that would help prevent the further release of these crystals if there was any damage to the inner ear. So just something to keep in mind, and we'd be looking at maybe 1,500 to 2,000 units. And vitamin D is used for other things as well too, but that's what we have been looking at as well.
Oh, that's great. Thank you. And we did just have one other one come in asking about your clinic and what the criteria are to be referred. And does the head injury need to be recent?
No, not at all. No. Matter of fact, no, our clinic is called the Hertz Multidisciplinary Neurology Clinic. It's a clinic at Toronto General Hospital or University Health Network. It is a clinic that is staffed by people like myself. We have our fellows, which are graduate doctors doing subspecialty training. We have vestibular physiotherapists that work with us, in addition to a vestibular nurse. And then we have a neuropsychologist, neurologist, and we have a vestibular psychiatrist. And it's a one-stop shop, for most people, where they get treated over the course of one day. And yes, I'm sorry, but we're the only clinic in Canada that does this, and probably North America. And it's a labor of love, believe me. And we do this, and the referral base either comes in from an ear, nose, and throat doctor who's seen you before in the past, or a neurologist. That's where we take the referrals from.
Okay, that's great. Thank you so much, Dr. Rutka, for an excellent talk and answering all of the questions that came in tonight. Thank you for everyone that attended. As always, there'll be a short survey coming your way. So if you have a couple minutes, please fill that out. And just a reminder that our next session will be in 2 weeks on April 16th, and we're going to have Dr. Marie Slager with us, and she's going to be talking about headache types and treatments. So thanks very much and have a good evening.